from MicrobeTV. This is Infectious Disease Puscast, episode 94, recorded on Monday, November 24th, 2025. Hello, everyone. I'm Dr. Daniel Griffin, and joining me today is Dr. Sara Dong.
Hi, everyone. I guess I'll use our little banter section just to say happy Thanksgiving to everyone. I guess this will come out right beforehand, right?
I think so. I don't know if you noticed in the section there, I have banter limit to 30 seconds. And we had a listener and they want us to be exactly 30 seconds so they can hit the fast forward through this. Because he's like, I love Infectious Disease Puscast. I just love all the information. It's so dense. But can you skip the banter? I was like, well, you could skip the banter.
Do we usually talk longer than 30 seconds? Maybe.
I think
they also do AI
exactly.
chapters now. Yeah.
Exactly. So you can just go click, click.
Oh, well, I hope it's around 30 seconds.
Okay.
All right. Well, welcome to another Puscast. References, as always, are available in our show notes at MicrobeTV, the home of our growing multimedia empire. Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
All right, we'll start off with our viral section. Remember to listen to This Week in Virology, both the clinical updates and the deep dives. I have to say that the last deep dive, actually, they deep dive into this first paper. So I will recommend that people go for a really good deep dive into this article. So we've got this article. Epstein-Barr virus reprograms autoreactive B cells as antigen-presenting cells in systemic lupus erythematosus, published in Science Translational Medicine. So not open access, which is a travesty. Apparently only us academics and people paying a fee can read the whole paper. But really critical discoveries in this paper. They identify a link between lupus and Epstein-Barr positive B cells that they tell us are predominantly CD27 positive, CD21 low memory B cells, and they're increased frequencies. They express a certain number of things. I feel like, they really on the deep dive did a great job. So I'm going to sort of pull from what they tell us in the deep dive. So they're looking at people that have lupus and they're looking at people that don't have lupus. And a couple things. By the time you reach a certain age, 95% of us end up with EBV infection. But the EBV only infects, about 1 or 2 per million B cells, right? So it's not really doing a lot of this. But in people with lupus, 25 times the number of B cells are infected. And specifically, those B cells that are being infected by Epstein-Barr virus are actually the B cells that produce autoreactive antibodies. And actually, one of the EBNAs, one of the actual proteins, the nuclear binding proteins in those B cells, is actually turning on, activating the B cells so that they're producing those autoantibodies. And actually, not only that, but it's actually activating them. So then they're also presenting histones and other antigens to T cells. So really this nice link between Epstein-Barr and lupus. As mentioned, they're demonstrating that SLE, so lupus EBV positive B cells, are serving as antigen presenting cells. They're driving the activation of T peripheral helper T cells. Amazing connection here.
Yeah, it's very cool. I pulled a paper from CID, hepatitis B reactivation following switch away from tenofovir-containing antiretroviral therapy in people living with HIV, a case series and lessons for practice. This manuscript shared 4 cases of Hep B reactivation in the setting of switching patients with HIV and prior Hep B exposure away from tenofovir-containing ART, as you gathered from the title. They also state that this is the first reported case of Hep B reactivation in a patient on 3TC containing ART, so dolutegravir, 3TC, lamivudine. And so you can see the cases summarized quite nicely in their figure 1, which I placed here. The time to Hep B reactivation ranged from 4 months to 12 months, but three of them were in that sort of 10, 11, 12 months, and the other patient, case 1, was 4 months. So they have some of the details there about the patient history, and shared some sort of lessons and talk through risk factors of Hep B reactivation. So I'm not going to read all of them, but I think good reminders that lack or low Hep B surface antibody titers increases the risk of reactivation, but the presence of a robust Hep B surface antibody does not confer full protection, really just not a perfect test for us to know. And I think just a good reminder to look at Hep B surface antigen, Hep B surface antibody, and Hep B PCR prior to switching off of these tenofovir ART regimens, and then kind of ideally screening these patients with likely Hep B surface antigen, Hep B DNA, and transaminases after the fact. Fortunately, none of these patients had fulminant hepatitis, but one of them did require hospitalization. So I thought this was just a really good review and something to think about as our ART regimens continue to evolve.
Now, this is, I have to say, great selection to have this in here, because a lot of HIV care is done by primary care doctors, right? So I certainly can see an ID specialist thinking about all this, but here you are thinking, oh, I'm going to be switching the regimen, and not necessarily realizing how important that hepatitis B aspect of the ART selection is. So nice to hammer it home with 4 cases of this does happen. This is real, not just some sort of myth we've been teaching people. All right, the article, Antimicrobial Drug-Resistant Neisseria Gonorrhea Infections in Men Using Doxycycline Post-Exposure Prophylaxis, a sub-study of the ANRS 174 DoxyVac trial published in CID. So, all right, what's the story? Bacterial sexually transmitted infection prevention by post-doxycycline prophylaxis, doxy-PEP, so doxy post-exposure prophylaxis in men who have sex with men, has raised concerns about the potential for antimicrobial drug resistance, AMR. So this group studied the impact of doxy-PEP on Neisseria gonorrhea antimicrobial resistance. In this investigation, MSM on HIV PrEP randomized to doxy-PEP 362 and no-PEP 183 were tested for GC at baseline and every 3 months thereafter by culture and NAD, nucleic acid amplification testing. MICs were determined with e-test and interpreted using the UCLAS guidelines. That's fine for those that want to care about that. They performed whole genome sequencing and or PCR sequencing. Now, from January 2020 to February 2023, MICs were determined for 78 GC isolates. We're only talking about a few hundred folks here, so we're getting a lot of isolates. And 233 NAT-only GC-positive samples were analyzed to identify the molecular determinants of resistance. All GC isolates were resistant to tetracycline, with a significant increase in rate of high-level tetracycline resistance mediated by the TET-M gene in the doxy-PEP arm than in the no-PEP arm. So this was 35.5 versus 12.5, so about threefold higher. The MICs of ceftriaxone, fluoroquinolones, azithro were similarly distributed, as we would suspect. All GC isolates were susceptible to ceftriaxone and cefixime, but isolates with decreased susceptibility to cefixime linked to the mosaic PEN-A 34.007 allele were more frequent in the doxy-PEP arm than the no-PEP arm. That was, again, about a tripling, 32.3 versus 10%. So it appears that these concerns are valid, as doxy-PEP use was associated with significant increase in high-level tetracycline resistance and decreased susceptibility to cefixime in GC. It's a pretty graphical abstract, but I'm not sure it adds anything. But anyway, doxy-PEP, worried about AMR? Yes. All right. The article, HIV pre-exposure prophylaxis does not increase gonorrhea and chlamydia incidence in young Black and Hispanic men who have sex with men, an observational cohort study published in OFIB. Now, this is short and sweet, and I got to say, it really addresses this bias people had. So, this, I'm so frustrated. And I've heard this from doctors. These people, now that they're on PrEP, they're not using protection. They get all these other STDs. They're not thinking about it. They're saying STDs, right? As opposed to, I'm woke and I say STIs, right? Of course. But is it really true? Is it really true? Because if you think when an individual is on PrEP, every 3 months, they got to meet with you. You got to talk to them. You get a chance to give them advice. You get a chance to talk about the risk of sexually transmitted infections. And so they really ask the question, is it really true? Are these people really getting all this gonorrhea and chlamydia? So they looked at PrEP, compared with periods not on PrEP, and found that while participants reported on average 2.5 more condomless sex partners, there were also more likely, 2.28, so an odds ratio, which is looking pretty good, more likely to report getting STI testing. So you think, oh my gosh, they're already stacked against them. They're on this PrEP. They're getting tested twice as often. But you did not actually see increased incidence of gonorrhea or chlamydia. And actually, there was a trend towards a lower incidence while on PrEP compared with not on PrEP.
Excellent.
All right. So throw those biases out the window.
Yeah. Well, next we have our bacterial section. Be sure to listen to This Week in Microbiology. I think I pulled several papers for this section this week. The first one I have is from New England Journal of Medicine, a multi-component intervention to improve maternal infection outcomes. This was a cluster randomized trial to assess this intervention called Active Prevention and Treatment of Maternal Sepsis, APT-sepsis. And so the goals of this program were to help adhere to a couple things. They had kind of 3 goals: adhering to WHO hand hygiene standards, adopting evidence-based practices for maternal infection prevention and management, early detection of sepsis, and use of FAST-M, which was an acronym for fluid, antibiotics, source control, transfer if required, and monitoring. So as a treatment bundle. And of course, there's more details. I pulled the one picture that kind of has these 3 overarching sort of primary buckets of goals and some of the strategies that they used, champions that they worked with, and so on. So there were 59 health facilities included where over 430,000 women gave birth during the trial. These were in Malawi and Uganda, and there were 30 clusters assigned to intervention and then 29 clusters assigned to usual care. And the primary outcome was composite of infection-related maternal death, infection-related near-miss event, or severe infection-related illness. And that was sort of categorized as deep surgical site, deep perineal, or body cavity infection. And this is among women who were pregnant or recently pregnant. And so this primary outcome occurred in 1.4% of patients in the intervention group versus 1.9% in the usual care group. So that risk ratio was 0.68 with a p-value less than 0.001. And it was generally consistent across countries, among facilities of different sizes, because they had a wide variety of included facilities. And so the program led, as you can tell, to significant benefit. And, this is a pretty large scale, wide variety of facilities included. We've actually brought up a couple of the papers, I feel like, that have come over the past year or two on azithro prophylaxis on Puscast and how that has not necessarily been routinely implemented. But this intervention reduced risk of maternal infection through targeted antibiotics and multiple sort of non-pharmacologic changes in care, which we talked about in those 3 buckets. So it's sort of good and bad. It's focused on clinical outcomes, so we don't have specific kind of micro data, diagnoses, resistance, those type of details, but I think still pretty exciting. And then I also pulled, in addition to the chart, the graph just kind of showing the percentage of patients comparing the baseline and intervention phases and that sort of separation and usual care and intervention and how those patients did better.
I like the acronym. If we just give a little bit of air to FAST, fluid, antibiotic, source control, right? AI always forgets source control. And then,
Yeah.
transfer if you need a higher level of care, if you need more help. All right, the article, and I love this one. This will be my favorite child this week. Global, well, actually, the lupus one is really, well, okay, I'm going to have two favorite children this week. Global and regional knowledge of antibiotic use and resistance among the general public, a systematic review and meta-analysis published in CMI. And I think it's really important to ask this question, because those of us in the field sort of think, well, we know like antibiotics, they treat bacteria. They don't do anything about viruses. But what does the public really know? So they go ahead and they identify 13,960 articles, end up finally 227 studies from 98 countries are included. Now, here's what they tell us. So they look through all this and they identify that the majority of the public correctly understood that antibiotics are effective against bacterial infections. Right. And the majority, about 73%. So 1 in 4, a quarter of people don't really get that antibiotics actually work against bacterial infections. Now, only 42%, so the minority, recognize that antibiotics are ineffective against viral infections. Kind of amazing, right? So most people thought that if you've got a viral infection, that an antibiotic is going to be helpful. Little sort of subtleties in there, right? Because I'd hate to have this discussion. Well, what do you mean by antibiotics? Are we including antivirals? Don't you really mean antibacterial agents? And anyway, so just like, let's not go down that rabbit hole. I just went down it myself. All right. Now, this really actually varied a lot by where you were, right? Because there I was suggesting maybe there was a sophisticated argument creating confusion. That's not what they found. So in places like Laos or the DR, for instance, you're going to find about 7% thought that antibiotics were good against everything, including those viral infections. Now, a place like Sweden, 77% realized that antibiotics were ineffective against viral infections. So really what they end up telling us is that these findings indicate that a substantial proportion of the public is aware that unnecessary antibiotic use reduces their effectiveness. So that's good. About 72% realize if we overuse these, we're going to lose them. The other, which is a little concerning, is that fewer individuals realize that, if one person gets treated and develops an antibiotic-resistant bacteria, that can then spread to another person. So they didn't really realize the ecology issue there, that as a population, if we're overusing the antibiotics, we're basically, impacting our environment.
So interesting. It makes me think about when I watch, like a pop culture or some interview with like a celebrity, and sometimes they'll be quizzing them trivia and they'll ask very simple ID things, and the things that folks get correct or incorrect. It's always fascinating. All right. This next one is just really for awareness. I think many folks in the ID community probably have heard this and are folks who have young children, but there is an ongoing U.S. outbreak of at least, the last I checked, 31 cases in 13 states of botulism cases in babies. These have been linked to specific lots of By Heart, so that's the name or the brand, whole nutrition infant formula. And so now By Heart has recalled their formula, but this was present in many stores: Walmart, Target, Kroger, Sprouts, Safeway, really you name it, as well as on online retailers. Infants with reported cases have ranged from 2 weeks to 6.5 months of age. All have been hospitalized and treated with Baby Big immune globulin. And so, as a refresher for those who are maybe not pediatricians or pediatric ID folks, infant botulism is caused by ingestion of the Clostridium botulinum spores. They then colonize in the infant's large intestine, replicate, produce botulinum neurotoxin. And so the classic symptoms are things like poor feeding, maybe ptosis, weak cry, constipation. But then with progression, babies can have difficulty breathing. We often sort of hear this term floppy baby, even arrest. So Administration of Baby Big can reduce the length of stay and disease severity. But I think what's difficult is symptoms of this can be pretty nonspecific. Weakness and poor feeding can be misdiagnosed as a lot of things, including sepsis. And it can be overlooked. So just a reminder for folks, I think I think community pediatricians are frequently calling in, trying to navigate this. But I put the link to the CDC website and the FDA and just a picture of the most common, that infant formula that was recalled.
Yeah, we had a case here actually before the alert went out at one of our local hospitals, try to keep everyone's anonymity and preservation. But my daughter, who's a PICU nurse, we're very proud of her. She was actually describing. And I think it was one of the residents, early on was like, hey, could this be botulism? You always love them, thinking of stuff. And I think that was enough for people to go, huh, yes, it could be.
Yeah.
CDC got involved. And apparently the Baby Big, according to my daughter, it's all made and stored out in California and needed to be distributed from California.
Yeah.
You're nodding. My daughter.
Yeah. Well, because because we all have to review where they are when it comes up. Yeah. I've only had, I think, 1 or 2 cases since being in residency. But it's quite scary. And I think people think there's going to be this story about honey, but usually it's not necessarily that you're going to have some history like that. At least now we know about an outbreak, but it sounds like, obviously in some of those early cases, they didn't have the luxury of having that insight early on.
Yeah. No, and this was a formula fed baby. So probably part of this whole situation here. So, All right. And also another reason why, we need a functional CDC, who you going to call. So.
Wouldn't that be nice?
All right. The article, Vitamin D Deficiency at Hospital Admission with Community-Acquired Pneumonia Associated with Increased Risk of Mortality, a prospective cohort study published in Open Forum Infectious Disease. I'm just going to cut to the chase in this because I thought it was really interesting. So they've got 514 participants. And they've got them in these groups of deficient and insufficient, but it really is going to turn out it's the deficient folks that matter. So vitamin D deficiency was associated with higher 90 and 100-day mortality risk. So 90-day, a 3.5 odds ratio. So more than threefold risk of dying compared with participants with sufficient vitamin D status. No differences were observed for in-hospital or 30-day mortality. So it took a little time, which is really interesting, right? That they actually had to follow them out. First 30 days, everything seems to be, and it's really in that once you get to 90, and that's pretty big, 3.5, and the 180, 3.27. So big difference there.
And then I will round out our bacterial section. I pulled this paper from Emerging Infectious Diseases, Bat-Associated Hemotropic Mycoplasmas in Immunosuppressed Children, Spain, 2024. I didn't really know anything about this, so that's why I grabbed it. This paper reported detection of hemotropic mycoplasmas in 4 immunosuppressed children. 2 of those were solid organ transplant recipients. 1 was a stem cell transplant recipient, and 1 child had cancer. These hemotropic mycoplasmas or hemoplasmas are small bacteria that can induce hemolytic anemia in mammals. So it's usually reported in veterinary medicine, but there have been some rare cases reported in humans. And the sequences of these mycoplasmas were identical to a strain previously identified in Schreiber's bats. I Googled a picture and it looks like what I picture as a bat. I don't have anything additional to say, but, raised concerns for zoonotic transmission. And so all these children had household pets, but there was no sign that their pet was a source of infection, and there's no clear contact with clear exposure to bats. The children also, some of them lived quite far apart, up to 500 kilometers. But I did learn that those bats are widespread in Spain. They can roost in caves, but also, abandoned buildings and tunnels, and maybe cause indirect human exposure. And so, there was no direct clinical effect noted in this, but I think it was basically that they were looking for organisms in immunosuppressed patients and found these and were a little surprised and confused and wondering about where these came from. Was it vector-borne? Could it have been transfusion-associated? And of course, detecting it through PCR doesn't necessarily tell us that there is an issue or that it's viable, but I should also say that all those cycle thresholds are quite high. But the question of whether or not this could be an issue, especially because these can persist in the bloodstream, is just something to think about. So I learned a couple things. I learned about hemoplasmas as well as the bats. So keep an eye out on that. And I will walk us into our fungal section. I grabbed a paper from the Lancet ID, mostly just to share one of the figures. This is the British Society for Medical Mycology Best Practice Recommendations for the Diagnosis of Serious Fungal Diseases 2025 update. And so there weren't any major changes. This updated some guidance from about I think 2015, if I remember correctly. So I'm not really going to focus too much on the details. You can see their overarching best practice recommendations in the primary summary panel. But I grabbed figure 2 because it just had this really nice circle diagram looking at testing options for serious fungal diseases and sort of source of where you would be sending samples like respiratory versus blood, tissue, or fluid. And sort of they have this nice breakdown of molecular versus conventional or antigen if it's available. So I think it's actually a really nice tool probably to talk about fungal testing, for example, with trainees when you're on service. So something that you can save on your collection of images for teaching.
I like it. Really nice.
It's very cool.
All right. And speaking about more fungi and resistance, putting it all together here, we have a couple articles. The first, in vivo evolution of Candida auris. I'm going to resist the renaming on that bug. I'm just going to keep calling it. Candida auris multidrug resistance in a patient receiving antifungal treatment was published in JID. So as our listeners well know, Candida auris is associated with life-threatening invasive disease due to a high level of drug resistance. So here, these investigators present a clinical case of C. auris multidrug resistance development in a patient acquired during antifungal treatment. So 5 isolates were prospectively recovered from a lung transplant patient receiving antifungal therapy over a 1-year period. While isolates were initially resistant to fluconazole, the terminal isolate became resistant to caspofungin and amphotericin B with significant increase in micafungin minimum inhibitory concentration. So they went ahead and did sequencing of the ERG11 and the FKS1 genes, identifying mutations associated with fluconazole and echinocandin resistant in the multidrug resistant isolate, really underscoring the threat of therapy-induced development of resistance. And I think this is important, right? Because we do have these individuals. A lot of times the individuals with Candida auris are sort of approaching the end of their life. So really important to be thinking about the potential risks in prolonged antifungal treatment. All right. And Candida parapsilosis, the article Increasing Fluconazole Resistance in Candida parapsilosis, a 10-year analysis of blood culture isolates at a U.S. reference lab 2015-2024, published in JID. So what do you think? Is there going to be an increase in resistance? Let's go in. Here we read that antifungal susceptibility testing among 1,740 Candida parapsilosis blood isolates submitted to the United States reference lab revealed a significant increase in fluconazole resistance from 8.2 to 20.3%. And we have this odds ratio, about a 13% increase per year, with really a notable acceleration since 2021. Voriconazole resistance remains stable, mycofungin resistance was rare, but intermediate susceptibility significantly increased, especially after 2021. So we're headed in the wrong direction. All right, parasitic. Be sure to listen to This Week in Parasitism. The article, Implications of a Fatal Anaphylactic Reaction Occurring 4 Hours After Eating Beef in a Young Man with IgE Antibodies to Galactose Alpha 1,3. Galactose was published in the Journal of Allergy and Clinical Immunology. So I gotta say, this is one of those ones that maybe non-ID docs might find really interesting and worrisome. It's one of the ones you can tell, like, hey, Thanksgiving's coming up, right? You could tell this around the turkey table. So
I feel like this was picked up in some like regular press.
I think it did. I think it probably got
articles
picked up
too,
because it's
yeah.
so good. So I don't know if our listeners are familiar with this, but here's the story. So it's summer of 2024. So it's last summer, like more than a year ago. A 47-year-old airline pilot with no past medical history, right? So no pre-existing medical conditions. He's just a healthy guy, goes on a camping trip with his wife and children. And he is like your normal guy, right? So after a day outside, they ate supper at 10 p.m., a little late for me, but okay, including beefsteak. I'm not sure, what is beefsteak? Basically, they're some kind of a cow. They're eating like steak, but from a cow, which apparently was, as they say, unusual because the family typically ate chicken. That will be relevant, but so the man wakes up at 2 a.m. with abdominal discomfort, which became so severe that he was writhing in pain, having diarrhea, and vomiting. After 2 hours, his condition improved. He goes back to sleep. In the morning, after almost dying, he feels well enough to walk 5 miles and then eats breakfast. He discussed the event with his wife. They considered consulting a doctor, but concluded, what would we say happened? On the other hand, he tells one of his sons during the episode, I thought I was going to die, right? So that's the typical guy thing, right? You know, you tell your wife, well, it really wasn't a big thing. And then you confide in your son, yeah, I thought I was going to die. Don't tell your mom. Now, 2 weeks later, he's home in New Jersey. He and his wife went to a barbecue where he ate a hamburger, and he eats the hamburger at approximately 3 p.m. Now, after going home, he mows the lawn. He's a good guy. He's participating, helping out. Takes about an hour. So I guess he's either got a big lawn or he mows slowly. But he had some GI symptoms. His wife leaves the house at about 7 o'clock. At about 7:20, he went to the bathroom. And by 7:30, their son was on the phone with their mother saying, Dad is getting sick again. Shortly thereafter, he found his father unconscious on the floor of the bathroom, vomit around him. Son calls 911. Paramedics come. They continue the resuscitation that the son had started. Transfers to hospital, 10:55. The man has died. Now, what happened here? So they did a postmortem. And one of the things they noticed is the total IgE was low, but the IgE to alpha-gal, they give us a level. In addition, the IgE to beef was positive. This level of IgE that they give us to alpha-gal represented 3.4% of his total IgE, and values over 1% are generally regarded as relevant. The Mayo Clinic provides a specific test for a postmortem tryptase. Tryptase value is really high, consistent with the highest levels in cases of fatal anaphylaxis. So why are we presenting this on ID Puscast? Because the whole issue here is what we're seeing is you get a bite by a particular type of tick. And then something in that saliva actually will sensitize you. And then basically you'll become allergic to red meat. And so that's what we think happened in this situation. Some point in time, this man was sensitized, got bitten by a tick. I should mention these ticks are expanding in not only their area, but also probably their frequency. So this man got bit by a tick. It made him anaphylactic level allergic to red meat. He didn't know, went ahead, ate red meat, and had this fatal outcome. All right, another reason to become a vegetarian. The article, Effectiveness of the RTS, S/AS01E malaria vaccine in a real-world setting over 1 year of follow-up after the 3-dose primary schedule. An interim analysis of a phase 4 study in Ghana, Kenya, and Malawi was published in the Lancet Global Health. So a little bit of background here. Malaria vaccine. So in 2015, WHO set ambitious goals to reduce global malaria incidence and mortality by at least 90% by 2030. Eliminate malaria from at least 35 countries and prevent its reestablishment in malaria-free countries. Good luck, US. Prevention of infection is based mainly on control of the mosquito vector using insecticide-treated bed nets and indoor residual spraying, which are limited by outdoor vector transmission and increasing insecticide resistance, as well as employing chemo prevention in pregnant women and children. But despite these measures, progress in disease control has stalled over the past few years in countries with a high malaria burden. According to the latest WHO estimates in 2023, there were approximately 263 million individuals with malaria, 597,000 malaria deaths worldwide. Over 95% of these deaths occurred in Africa. 76% were in children younger than 5. Now, the hope is in this context that an effective malaria vaccine could be an additional tool. I want to point out, this is not a situation where we think that we'll vaccinate, everything will go away. This is probably going to be another tool that has to be used with the others. And so sort of different than smallpox, where we can just, go around and just use a vaccine to get rid of this. And part of the way I say that is because, there's differential efficacy of vaccines based upon how many of the other things are in place and really the surrounding incidence of malaria. But in terms of vaccines, there's 2 candidates that really stand out. So there's the RTS, S/AS01. That's the one we're talking about today. And then there's the R21 Matrix M vaccine. Now, I'm going to say this, and then you're going to say, why are we talking about this? But so I'm going to say that the data to date suggests that the R21 Matrix M vaccine is probably more effective in the initial trials and also appears to be more cost-effective and easier to produce than the RTS. Okay? But so here we're going to talk about the RTS. Now, here we have a large multi-center phase 3 trial. 4 doses of malaria vaccine, the RTS one, showed efficacy against clinical malaria in children aged 5 to 17 months at first vaccination, leading to reductions in the incidence of clinical malaria by 39% and of severe malaria by 29% in vaccinated versus unvaccinated children over 4 years of follow-up. Now, here we've got the results of the interim analysis of the EPIMAL-003 study, which is a phase 4, so sort of after the phase 3 disease surveillance study with prospective cohort event monitoring. Studies performed in routine medical practice settings at 12 sites, 4 per country, Ghana, Kenya, Malawi. Children younger than 18 months were enrolled in exposed clusters and unexposed clusters. Data was collected via active surveillance. In an interim analysis, we see that actually the results are pretty similar to what we saw. So when they compared what we saw in the initial trial, so when comparing vaccinated children with unvaccinated children, incident rates ratios were 0.70, so about a 30% reduction for any malaria, 0.42 for severe malaria. So that's actually a little bit better, right? 58%, 0.64 for malaria-related hospitalizations. So 36% reduction. So it looked like the real world experience was consistent or maybe even a little bit better than the RCTs. Okay. All right, let's talk about ivermectin. Hashtag ivermectin. Maybe more people will listen whenever you talk about the wonder drug. But the article, A Systematic Review and an individual patient data meta-analysis of ivermectin use in children weighing less than 15 kilograms. Is it time to reconsider the current contraindication? So I don't know if our listeners know this. This is sort of those of us that actually used ivermectin before the pandemic and those of us that use it properly after the pandemic and during the pandemic. Ivermectin use is considered contraindicated in children weighing less than 50 kilograms, restricting access to this drug for the treatment of NTD, so neglected tropical diseases. They found that 1,088 children weighing less than 15 kilograms were actually administered oral ivermectin for one of the following indications. So scabies, mass drug administration for scabies control, crusted scabies, cutaneous larval migrans, myiasis, pityriasis, strongyloidiasis, trichoriasis, and parasitic disease of unknown origin. Now, overall, a total of 1.4%, I'll say only 1.4% of children experienced 18 different adverse events, all of which were self-limiting. They found that existing but limited data suggests that oral ivermectin in children weighing less than 15 kilograms is safe.
All right. And I will close us out. I grabbed this one because I had actually a new diagnosis of this on service sometime earlier this year. And also one of my colleagues, Alicia Johnson's on this paper. And of course, there's a ton of other big names related to inborn errors in here and folks who work at NIH. So this is from CID, IL-12 receptor beta 1 deficiency appearing in North America, expanding the clinical phenotypes. And I just think this topic is so interesting, and I just like an excuse to read about it. So interleukin 12 receptor beta 1 deficiency is the most common genetic form of Mendelian susceptibility to mycobacterial disease globally. And usually we think of that as presenting with disseminated BCG infection. But of course, here in North America, where we are not using BCG, it can instead pop up as a kind of more distinct clinical phenotype shaped by our setting and exposures with different bacterial or fungal infections. And so this was a retrospective review of 14 individuals with this deficiency, half managed at NIH and half at other sites across the US. This makes it the largest series of IL-12 receptor beta 1 deficiency in North America. The median age at first presentation was 6 years old. And they found that infections caused by NTM were found in 7 of those cases, non-typhoidal salmonella in 2 patients, and candida infections in 5 patients. All of the reported NTM infections were disseminated and severe and related to MAC. 3 patients, all of whom resided in endemic areas in the U.S., had disseminated non-meningeal coccidioidomycosis. And so, basically this is a series really pointing out that we should think about it probably with patients who have these severe intracellular infections. And that might be NTM and salmonella, but it might be others. And so the infection complications in this series were quite severe. There were 4 fatalities despite having very intensive antibiotic therapies and some with adjunctive exogenous interferon. And so obviously these are probably a collection of quite complex cases, but I think ultimately the mortality rate is probably not too far off. In their series, it was 29% in that cohort. There's a larger international series that quoted about 32% for a mortality rate. So although it's overall a rare entity, you never know when you might see it, and something to keep in mind if you have a patient who has that sort of unexpected or more severe response to some of these infections. All right. And that brings us to the end of this podcast. As always, the references for this show are available at MicrobeTV, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast, or grab it with your favorite podcatcher or on YouTube. And then make sure to subscribe, like us, ring the bell, and leave comments. We love to get your questions, comments, and paper suggestions. Send them to puscast@microbe.tv. If you like what we do, or you just want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute, or we're in our fundraiser. Go to parasiteswithoutborders.com and click on the donate button.
I'm Sara Dong. You can find me on Blue Sky at sarawindong.febralpodcast.com or, of course, over at Febral Podcast.
All right, I'm Dr. Daniel Griffin. You can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another podcast is Infectious.